In this video, you will see the three basic electrophysiological properties that are needed for successful reentry. Explanation why conduction into the transversal direction is slower than in longitudinal. And what is the difference between anatomical and functional reentry. You can use the timecodes to check the most relevant information for you. Let's go! There are two basic groups of electrophysiological mechanisms that cause cardiac arrhythmias. The first one is abnormal impulse initiation. That includes automaticity and triggered activity. And the second one is abnormal impulse conduction. That in turn includes conduction block that leads to ectopic pacemaker escape and reentry. But firstly, let's check how normally impulse goes through the myocardium. After each normal cardiac cycle, tissue is in an effective refractory period. During this time, cardiac cells can be excited again. Relative refractory period follows after effective refractory period. If the stimulation occurs at this time, conduction speed decreases. Full recovery of cells' excitability occurs only after termination of relative refractory period. Reentry occurs when a propagating impulse fails to die out after normal activation and persists to re-excite the heart after expiration of refractory period. Classically, reentry is explained by the ring model. The ring is a model of an anatomical reentrant circuit, an anatomical fixed pathway of excitable cardiac muscle that is located around unexcitable central region. Conducted impulses are indicated by the arrows with head of propagated impulse and the blue segment of arrow's tail that indicates effective refractory period, time when cardiac cells can be excited again due to the inactivation of sodium channels. The red segment of the tail indicates partial recovered myocardium during the relative refractory period. The three basic electrophysiological properties that are needed for successful reentry are unidirectional block, area of slow conduction, and time course of recovery of excitability of tissue in the pathway. Let's explain how unidirectional block works. When an impulse enters to the ring model, it splits into two impulses which collide at another end of the circle. As a result, reentry does not occur. In the situation when we have block in clockwise direction, one of the splitted impulses is blocked, but another one propagates around the ring in counterclockwise direction. If conduction is restored in the region of the block, the impulse can then return to its site of origin and re-excite or re-enter to the tissue that is previously has excited. In this case, the unidirectional block is transient. Also, reentry can occur when persistent unidirectional block is present. In this case, impulse can pass in clockwise direction, but when it goes around the circle, it can be propagated through the block region in counterclockwise direction and continue to repeat the circulation around the circle. In addition to unidirectional conduction block, for reentry to occur, the impulse that is conducting around the circuit must always find excitable tissue in the way of propagation. For purposes of describing the mechanism of reentry, we will use concept of wavelengths of conduction impulse. A definition of wavelengths is a distance traveled by the depolarization wave during the time the tissue restores its excitability sufficiently to propagate another impulse. Thus, wavelengths is equal conduction velocity multiplied by effective refractory period. In a schematic picture, the distance from the arrowhead to the end of effective refractory period reflects wavelengths. For reentry formation, wavelengths always should be smaller than the path length or L. If the wavelength is smaller than the path length, there is an excitable tissue between the head of current wave and the tail of preceding wave. This excitable part of the circle is called excitable gap. Excitable gap can be spatial and temporal. Excitable region of the circuit forms a spatial excitable gap that is measured in millimeters. But in clinical study, temporal excitable gap is usually used. Temporal excitable gap is a time interval between the head of activation of the impulse and tail of refractoriness of previous impulse. That is measured in milliseconds. Every excitable gap can be full and partial. Full excitable gap means the tissue has fully restored its excitability. so relative refractory period has been terminated. The partial excitable gap is when the wave is propagated in relative refractory tail when excitability is still not fully restored. So why the excitable gap is so important? When conduction velocity and/or effective refractory period is increased, therefore the wavelength is increased too. Wavelengths can be even bigger than the path length. In this case, arrowhead goes around the circuit and after colliding with the tail expires. So there is no excitable gap in this case. No excitable gap means no excitable tissue for further maintaining of reentry, thus reentry disappears. So if the path length is constant, either conduction velocity or effective refractory period prolongation leads to excitable gap shortening, that in turn finishes the reentry or needs the path length prolongation. But path length prolongation is limited by the relatively small amount of cardiac tissue. Therefore, slowing of conduction that leads to wavelength shortening and excitable gap prolongation is crucial to reentry maintenance. A slow conduction of velocity can be due to a consequence of changes in active membrane properties. Determine the characteristics of inward current depolarizing the membrane, especially during the phase 0. That includes an amplitude of action potential or rate of phase 0. Or it also can be consequence of change in passive properties, governing the flow current between the cardiac cells through the gap junctional channels. Both mechanisms often participate simultaneously. Let's explain the changes of phase 0 of action potential. Here you see the three cells that are connected electrically by the gap junctions. When the cell is in a resting state, the external side of the cell membrane is charged positively and the internal negatively. The membrane potential in this case is minus 90 mV. Cell in fourth phase of action potential, resting potential. When the first cells start to depolarize, during the phase 0, sodium channel opens and sodium enters to the cell. The membrane potential charges change to the opposite. Membrane potential becomes plus 30 mV. The sodium current conducts to the neighbor cell through the gap junction. This current is called axial current. In turn, it makes the membrane potential of second cell less negative and continues to depolarize the second cell until it reaches the threshold for sodium channel activation that lead to beginning of phase 0. Should be mentioned that ionic current also flows out of the second cell through the IK1 channels. After this, all processes repeat by second and the third cell. So excited cell that generates the axial current is the source. The unexcited cell that obtains the axial current is the sink. The current of the source cell, when large enough, can flow for several cells, from cell 1 to cell 2 and 3 simultaneously. As a result, conduction speed increases. For normal conduction to occur, the number of positive charges delivered by the source to the sink should be greater than the number of positive charges leaving the cells at the sink by the IK1 channels. This property is responsible for depolarization of membrane potential to threshold for generation of action potential in cells of the sink. There is an impedance match between the source and the sink, meaning that the resistance to axial current flow or impedance allows sufficient axial current that matches the requirements for depolarization of the sink to threshold potential. The ability to conduct an impulse from the one cell to the next can be expressed in terms of safety factor for conduction. This is a measurement of reliability of conduction expressed as the ratio of the amount of net current generated by the source and the minimal amount of current required to excite the sink cells. A safety factor greater than 1 indicates more than sufficient current generated by the source for propagation, while safety factor less than 1 causes propagation to fail because the sink is not depolarized to threshold potential. If the either rate or amplitude of phase 0 decreases for some reason, less sodium enters to the cell, membrane potential reaches a less positive value. Thus, axial current is less strong. Therefore, more time is needed for depolarizing the sink to the threshold. As a result, conduction slows. Also, when axial current is not strong enough, it can flow to the few cells simultaneously, which also slows conduction. In the situation when the resting membrane potential of the sink cell is less negative, after normal axial current from the source, amplitude and rate of phase zero of action potential in second cell is reduced. In turn, the second cell axial current needs more time for depolarizing the sink to the threshold, therefore conduction slows again. What is the reason for an activation of sodium channel during the phase 0? It occurs when the cell is activated during the phase 3 of action potential, when it is in the relative refractory period, or due to reduction in membrane potential in diseased tissue. Here we see the propagation of impulse from the region A through the region B to region C. When it occurs after termination of relative refractory period, conduction speed is not impaired. When the premature impulse occurs in region A, it conducts to the region B during the third phase of action potential. As a result, starting point of the action potential in region B is less negative. Thus, amplitude of phase 0 of action potential is reduced. Axial current is decreased, that leads to slowing of conduction speed from the region B to region C. What happens in diseased tissue? As you see, region A has normal resting membrane potential, minus 90 mV. However, the region B is diseased and has less negative membrane potential, minus 65 mV. Region C has normal resting membrane potential. The first, the second, and the third action potential in the site A conduct slowly through the site B because of inactivation of sodium channel at this site, reflected by the slow phase 0 and reduced action potential amplitude. When the fourth action potential at the site A occurs at the shorter cycle length and arrives earlier at the site B, in this time, in site B membrane potential is reduced and refractory periods can even outlast the complete repolarization. This phenomenon is called post-repolarization refractoriness. That in turn leads to further reduction of action potential amplitude in site B, thus conduction from the site B to site C is slower. Conduction of subsequent action potential from the site A will block at site B even when they arrive well after complete repolarization because of the post-repolarization refractoriness. Now let's talk about gap junctions. There are two groups of factors that determine the gap junctional conductance: general and individual. Gap junctions are formed by special proteins that called connexins. Changing of connexin protein isoform can change the conduction properties of the gap junction. Other features that affect gap junction conductance are total surface area of gap junctions, the number of gap junction channels per unit of area. Also, gap junctional conductance can be reduced by elevated intracellular calcium level, for example due to the effects of digitalis, or by low intracellular pH below 6.5, as occurs in ischemia, a process that occurs over a longer period of time and reduced gap channel conductance called gap junctional remodeling. Remodeling can lead to changes in gap junctional protein expression or post-translational modifications. Normal aging as well as many pathological conditions are also accompanied by fibrosis of myocardium, which can disrupt gap junctional connections. All of these factors can lead to slowing of conduction through the gap junctions, or even can lead to conduction block. Other passive properties governing the flow of current between the cardiac cells through the gap junctions is anisotropic conduction. Look at the spreading of the impulse in both longitudinal and transversal direction in time frames from first to fifth. As a result, you see that conduction speed in longitudinal direction is greater than conduction speed in transversal direction. This phenomenon is called anisotropic conduction. Anisotropic conduction, meaning that conduction velocity varies depending on the direction in which impulse propagation occurs. The ratio between the longitudinal and transversal conduction velocities is called anisotropic ratio. This type of anisotropy is uniform, due to smooth gradual changing of conduction velocity from the longitudinal to transversal direction. The directional difference is caused by structure of the myocardium. Here you see the 6 myocardial cells. It should be noted that the length of the cell is much bigger than the cell's diameter. The ends of the cell are connected by the gap junction in longitudinal direction. They are orange. Gap junctions in transversal direction have a blue color. As you see, impulse propagates from one cell to another cell only near to the end of the cells. So if we take an equivalent distance in longitudinal and transversal directions, in the transversal directions the same distance encounters many more gap junctions, because the diameter of the cell is smaller than the length. Every gap junction provides a resistance to current flow. Therefore, more gap junction, more resistant to flow, more slower conduction. But for reentry, more important is non-uniform anisotropic conduction. Accumulation of connecting tissue in transversal direction due to aging or pathology processes leads to gap junctional disruption in transversal direction, unlike the maintaining of normal conduction in longitudinal direction. According to this, non-uniform anisotropy is defined as maintenance of tight electrical coupling between the cells in longitudinal direction with paucity of transverse direction that leads to irregular pattern of transverse conduction. When the gap junctions are disrupted, transverse conduction is provided by bridges of myocardium that penetrate the large amount of connective tissue. So here we have an abrupt slowing of transverse conduction, and as a result, the anisotropic ratio increases. The second crucial component of reentry is unidirectional conduction block. The unidirectional conduction block is blocked in one direction through the pathway, but maintaining conduction in the opposite direction. Unidirectional conduction block can be transient and persistent. It can be due to regional differences in recovery of excitability, asymmetrical depression of excitability, due to geometrical factors, and due to anisotropy. Let's start with regional differences in recovery of excitability. For example, one half of reentry ring has short action potential and thus short effective refractory period. Another one has long action potential and long effective refractory period respectively. The reason for this heterogeneity can be different. So when regular non-premature impulse enters to the circle, it reaches both parts of circle after the termination of effective refractory periods, and as a result, a splitted impulse collides in the lower part of the circle, and reentry does not occur. When the impulse is premature, situation is changed. After the splitting, impulse reaches the half with the long action potential during the effective refractory period, so the impulse causes only subthreshold small depolarization in repolarization phase, so conduction here is blocked. However, the same premature impulse conducts in the right pathway with shorter refractory period, reaches it after the termination of effective refractory period, so it can be conducted further and invades the unidirectional block region from the another side. The unidirectional block caused by premature impulse is transient, occurring only during the initiation of premature impulse. After the wavefront is launched in the clockwise direction around the circuit, the region of the initial unidirectional block recovers excitability and resumes its original property of bidirectional conduction. After this, impulse re-excites the region where the premature impulse originates. This region must have regained their excitability by the time the impulse that is conducted through the reentrant pathway arrives here, and all cycle repeats. When the premature impulse occurs too early, both left and right parts of the circle still do not recover excitability, so impulse reaches these sites during effective refractory periods. In this case, bidirectional block occurs. As a result, reentry doesn't form. So, as you see, premature contraction is necessary requirement for reentry initiation. Should be noted that it can have different than reentrant tachycardia mechanism, such as triggered activity or automatism, and also premature impulse can have different morphology. Let's go to asymmetrical depression of excitability. Usually, it causes a persistent unidirectional block. Here we have a muscle bundle with a region with the gradual ischemic changes from the normal cells in the left edge and the gray region of maximal ischemia. After the maximal ischemic part of the bundle, we see the normal non-ischemic region that is represented by light color. Now let's see how action potential and conduction will change in case of left to right direction of conduction. As you see, both action potential amplitude and as a result axial current decrease gradually toward to the maximal ischemic region. So even normal region after the ischemic part can't be excited because of extremely weak axial current of ischemic region. Thus, here conduction block occurs in left to right direction. However, in right to left direction, situation is not the same. The normal non-ischemic region has a strong axial current that can't induce enough depolarization in maximal ischemic region, but it can conduct to a few cells further. Therefore, in right to left direction, conduction is maintained. Thus, here we have unidirectional conduction block. Now go to the geometrical factors. On the left side, we see the one cell that is connected to the three cells in the right side by the gap junction. So a thin bundle of cell on the left side is connected to the thick bundle of the right side. So if the conduction goes in left to right direction, one left cell is the source and three right cells are sink. As a result, normal axial current of the source should be distributed between all sink cells. This axial current splitting can lead to decreasing of action potential amplitude of the sink cells, thus lead to slowing of conduction. But if the third cell initially has decreased resting membrane potential due to any reason, like an ischemia, in this case, source axial current initially is decreased. So after splitting, axial current is not able to cause sufficient sink cells depolarization. As a result, conduction block occurs in left to right direction due to source-sink mismatch. Now look at the opposite situation, right to left direction of conduction. In this situation, three right cells become source and one left cell becomes sink. Thus, three strong enough axial currents from the source depolarizes the sink. Axial currents collide and are strong enough to cause acceleration of conduction in this direction. So, unidirectional block occurs in left to right direction, however, right to left conduction is maintained. And the last reason for the unidirectional conduction block is anisotropic conduction. Basically, in non-uniform anisotropic conduction, safety factor in longitudinal direction is smaller than in transverse direction, and this is the key to understanding the unidirectional block formation due to anisotropy. So, if the short coupled premature contraction occurs, phase 0 in premature complex is reduced in amplitude and longer in duration. So, conduction block occurs on the longitudinal direction due to low safety factor, while the transverse conduction is maintained at low source currents. The transverse propagated wavefront can then propagate to the region distal to the region of the longitudinal block, and then conduct retrogradely back through this blocked region after it has recovered excitability by forming the reentry circle. The final requirement for reentry is cardiac tissue recovery of excitability, and we already know that decreasing of effective refractory period decreases the wavelength, thus increases the excitable gap, and also decreases necessary size of reentry circuit. Factors that can make effective refractory period shorter include tachycardia-dependent shortening of action potential and therefore effective refractory period. In reentry circles with a partial excitable gap when the head-to-tail interaction is present, this interaction accelerates the action potential and shortens the effective refractory period at the head of wavefront. Vocal stimulation in the atria, chronic ischemic areas in the ventricles and reperfusion after brief period of ischemia, and any changes of transmembrane currents that lead to refractory period shortening. Reentry circuits can be formed by anatomical structures. resulting in a fixed pathway when impulse travels around an excitable obstacle formed by anatomical structure, such as natural orifices or scars. For example, typical atrial flutter that is located in the right atrium and formed around the natural vessel's orifices. Or AV nodal reentry tachycardia that is located inside the AV node and related to congenital splitting of AV node into two conduction pathways. Reentry circuits can be also functional, formed because of specific electrophysiological properties of myocardial cells. This type of circuits is not dependent on the macroanatomical structures and central unexcitable region, but they are dependent on microanatomical structures such as gap junctional distribution and conduction anisotropy. There are three types of functional reentry: leading circle reentry, rotor reentry, and anisotropic reentry. Let's explain leading circle reentry. The electrophysiological properties for the tissue that is necessary for leading circle reentry is a region with a long effective refractory period. When premature impulse occurs, it blocks in the long effective refractory period site that forms transient unidirectional block, so impulse starts to travel around this region. When impulse reaches the same region from another site, excitability of this region is restored, and impulse can invade the long effective refractory period region, thus the reentry circuit starts to circulate. Slowing of conduction is represented by head-to-tail interaction. As a result, leading circle has partial excitable gap. The reentrant impulse conducts around the central region, that is kept refractory by the constant bombardment with impulses propagating centripetally. The central area provides functional obstacle that plays the same role as anatomical obstacle in anatomical circuit. The circle of the smallest reentrant pathway around the functional obstacle is called leading circle reentry. The circuit can move from one region to another because its location is not dependent on anatomical obstacle. It persists as long as new region has appropriate electrophysiological properties. When it moves, its size can also change if the new region has different refractory periods. The circuit can be small enough to allow multiple circuits to coexist simultaneously. Leading circle reentry may be a cause of focal reentrant tachycardias or participate in atrial and ventricular fibrillation. If you like the content, press like and subscribe buttons and have a good day. Here we go.